So, dear students and doctors, today I'll discuss about the various indication of beta blocker and various side effect of beta blocker. And these are a long list of indication of beta blocker, and I'll discuss one by one. Right? If you go to the internet, you can find some many other indications, but I'll list these indications. At least you have to know this. So first we can go into the hypertension, and let's see how does beta blocker lower your blood pressure. You first has to remember that beta blocker is not a first line antihypertensive in these days. The first line antihypertensive in these days is either calcium channel blocker or it is angiotensin receptor blocker. It is not the beta blocker. It is a calcium channel blocker or angiotensin receptor blocker or thyroid like diuretics are the first line antihypertensive agent in these days. Before understanding the antihypertensive of beta blocker, we need to look at the places where the beta 1 receptor is actually located. Beta 1 receptor is actually located in two places. One is heart and another one is kidney. So where is actually in the heart beta 1 receptor is located? In the heart there are many components, and beta 1 receptor is mainly concentrated on the SA node and on the AV node and on the ventricular muscle cell. These red color cell are ventricular muscle cell or ventricular myocyte. So these are the places where the beta 1 receptor is highly concentrated on the cells of SA node, on the cells of AV node, and on the ventricular muscle cell or myocardium of the heart. Other tissues contain beta 1 receptor, but their concentration of beta 1 receptor is less. And these are some highly concentrated places of beta 1 receptor like SA node, AV node, and ventricular muscle cell. Beta 1 receptor is also located in the kidney. You can see this is the glomerulus. This is glomerular capillaries, and this is the efferent arteriole, blood coming through the efferent arteriole, and this is the efferent arteriole, and this is the distal convoluted tubule. And in the distal convoluted tubule there are some specialized cell called macula densa, and this is afferent arteriolar JG cell, and this is interstitial cell, and all these cells together form juxtaglomerular complexes. And these cells in one of the afferent arteriole, some of the cells are modified, these green cells, and this green cell is called JG cell, and this JG cell contain beta 1 receptor on their surface. So JG cell of kidney contain beta 1 receptor on their surface, right? Now we need to look at uh, what is the effect of stimulation of this receptor. So as these receptors are part of sympathetic nervous system, we can draw, suppose this is central nervous system, and from central nervous system preganglionic neuron comes. This is preganglionic neuron, and preganglionic neuron synapse with another neuron called postganglionic neuron, and this postganglionic neuron release two neurotransmitter. One is epinephrine, another one is non-epinephrine. This epinephrine is also called adrenaline, and non-epinephrine is also called noradrenaline. And the neurotransmitter released by this postganglionic neuron is epinephrine and non-epinephrine. Let's suppose first they stimulate the AC node. So suppose this is the AC node, and on the surface of AC node there is beta 1 receptor, and this epinephrine and non-epinephrine stimulates the beta 1 receptor. When this epinephrine and non-epinephrine stimulates this beta 1 receptor, you know AC node has always in the heart undergoes spontaneous depolarization. Suppose AC node undergoes spontaneous depolarization 64 times per minute, right? So 64 times in a minute SA node undergoes spontaneous depolarization 64 times in a minute, let's suppose. And when SA node is stimulated by non-epinephrine and epinephrine. If non-epinephrine stimulates the SA node, then the spontaneous depolarization per minute, suppose let's see it is 90 per minute. So what you can see, epinephrine and non-epinephrine stimulates beta 1 receptor and they increase the rate of spontaneous depolarization. They increase the rate of spontaneous. Spontaneous word is important because SA node undergoes spontaneous depolarization. So epinephrine and non-epinephrine, by stimulating the beta 1 receptor, they increase the rate of spontaneous depolarization. And when SA node and AV node, epinephrine and non-epinephrine stimulates the SA node and there is increased rate of spontaneous depolarization, this leads to increase in heart rate, right? This leads to increase in heart rate. And when your heart rate is increased, this leads to increase in cardiac output, right? Because cardiac output depends on heart rate and stroke volume. So when your heart rate goes up, provided that your stroke volume is constant, so when your heart rate goes up, your cardiac output will go up. And when your cardiac output will go up, your systolic, your blood pressure will go up, right? So this is one effect of the stimulation of beta 1 receptor in the SA node, right? Now let's see what is the effect of stimulation of beta 1 receptor on the cardiac muscle cell. So again, this is the central nervous system, or more accurately I call it spinal cord. And from spinal cord, from C7 to T4 segment of the spinal cord actually innervates the heart, but this neuron comes from thoracic 2, 3, 4, maybe autonomic neuron, and this autonomic neuron actually gives preganglionic neuron. So this is the preganglionic neuron, and preganglionic neuron synapses with the postganglionic neuron, and this postganglionic neuron release non-epinephrine or epinephrine, and this non-epinephrine and epinephrine will stimulate the cardiac muscle cell. So suppose this is the heart muscle, this is the muscle of the heart or myocardium, you call it myocardium, and on the surface of myocardial muscle cell there is very high concentration of beta 1 receptor. And when non-epinephrine and epinephrine stimulates this beta 1 receptor, what happened? The contractility of the cardiac myocyte goes up. The most important term is contractility. Contractility. You may understand it or not, but you have to memorize it. When beta 1 receptor is stimulated by endogenous non-epinephrine and epinephrine, contractility of the cardiac muscle goes up. And when contractility goes up, this leads to increase in cardiac output, and increased cardiac output will lead to increase in blood pressure, right? So these are second important action. Third important action is that, suppose this is central nervous system again, and from CNS you get a preganglionic neuron, and preganglionic neuron synapses with a postganglionic neuron, and postganglionic neuron release non-epinephrine and epinephrine, and this non-epinephrine and epinephrine will stimulate JG cell, will stimulate beta 1 receptor on the JG cell, right? They will stimulate the beta 1 receptor. When the beta 1 receptor is stimulated, JG cell, in the JG cell will release renin, and renin will convert tensinogen, which comes from the liver, into angiotensin 1, right? You all know it. And when this angiotensin 1 passes through the lungs, in the lungs there is special enzyme called angiotensin converting enzyme, and this angiotensin 1 will be converted into angiotensin 2, and this angiotensin 2 will act on adrenal cortex of kidney. Suppose this is the adrenal gland of kidney or suprarenal gland. Angiotensin 2 act on adrenal gland of kidney and stimulates the release of aldosterone. And this angiotensin 2 and aldosterone together will retain fluid from the kidney. They retain salt and water from the kidney. They retain fluid from the kidney, and when they retain fluid, this leads to increase in blood volume, and this leads to increase in blood pressure. So these are the various mechanisms how the beta blocker will lead how the stimulation of beta 1 receptor by endogenous epinephrine and non-epinephrine will lead to increase in blood pressure. Now let's see how the beta blocker acts to reduce the blood pressure, right? To understand the mechanism of beta blocker, let's again what happened if we put a patient on beta blocker. Let's see this. This is again sympathetic nervous system. This is again central nervous system. Most accurate, the spinal cord preganglionic neuron comes. Its synapse with postganglionic neuron. Postganglionic neuron release epinephrine and non-epinephrine. But in this time, if you put a patient on beta blocker, suppose this is SA node and this is beta 1 receptor on the SA node, and if you put a patient beta blocker, right, this is suppose propanolol or atenolol, propanolol or atenolol or metoprolol. This beta blockers blocks beta 1 receptor. So endogenous non-epinephrine and epinephrine cannot bind with the beta 1 receptor. They cannot bind. So what will happen? Spontaneous depolarization on the SA node goes down. So spontaneous depolarization rate, rather I should say, depolarization rate in SA node will go down, and when depolarization rate in SA node will go down, heart rate will go down, right? Heart rate will go down, and when heart rate will go down, your cardiac output will go down, and when your cardiac output will go down, your blood pressure will go down, right? So this is one of the important mechanism of beta blocker, that it reduces the blood pressure. Second important mechanism of beta blocker, to understand this again, we draw the spinal cord of the central nervous system, and preganglionic neuron come, postganglionic neuron release epinephrine and non-epinephrine, and this epinephrine and non-epinephrine will stimulate cardiac muscle cell. On the cardiac muscle cell, there is beta 1 receptor, cardiac muscle, and on beta 1 receptor, and this epinephrine and non-epinephrine usually normally stimulates the beta 1 receptor. But when there is a beta blocker, epinephrine and non-epinephrine, suppose this is a beta blocker, and your epinephrine and non-epinephrine now cannot stimulate this beta 1 receptor. So what happened? When beta 1 receptor cannot be stimulated, there will be decreased contractility. Contractility of the cardiac muscle goes down. Contractility, this is very important. And when contractility of the cardiac muscle goes down, this leads to decrease in cardiac output, and when cardiac output is decreased, blood pressure is decreased, right? This is very important. When cardiac output is decreased, blood pressure is decreased. So due to presence of beta blocker, endogenous non-epinephrine and epinephrine cannot stimulate contractility in the cardiac muscle cells, so contractility goes down, and this leads to decrease in cardiac output, and this leads to reduction of your blood pressure. To understand the third mechanism of beta blocker, so again we can draw this is central nervous system, this is the CNS, more accurately spinal cord, and this is preganglionic neuron, and this is postganglionic neuron, and this is JG cell of kidney, this is the JG cell, and this JG cell, on the surface of this JG cell there is beta 1 receptor, and this beta 1 receptor, normally endogenous non-epinephrine and epinephrine stimulates this beta 1 receptor. But when there is a beta blocker, blocks this receptor, endogenous epinephrine and non-epinephrine cannot stimulate this beta 1 receptor on the JG cell. So when endogenous non-epinephrine and epinephrine cannot stimulate beta 1 receptor on the JG cell, there will be decreased release of renin from the kidney. Renin release is decreased. When renin is decreased, there is decreased angiotensin 2, right? You can understand. And when there is decreased angiotensin 2, there will be decreased aldo or aldosterone. And when there is decreased angiotensin 2 and aldosterone, less fluid is retained from the kidney, so fluid retention will be down. And when fluid retention from the kidney will be down, right, kidney will retain less amount of fluid, there is decreased blood pressure. So these are very three important mechanism. Another mechanism of antihypertensive action of beta blocker. Let's go into the Another mechanism of antihypertensive action of beta blocker is that uh, actually this is central nervous system, right? I'm not good at drawing. Suppose this is the central nervous system, brain and spinal cord, and any substances that want to enter into the brain and the spinal cord, they must have to cross the blood-brain barrier, right? They have to cross the blood-brain barrier. So suppose this is the blood-brain barrier, and they have to cross this blood-brain barrier, and this blood-brain barrier is made up of what substances? Lipid. This blood-brain barrier is made up of lipid, and lipid soluble beta blocker like propanolol enters into the brain, right? Enters into the brain because they can cross the lipid, and they decrease adrenergic drive from the brain. So they decrease the adrenergic drive from the brain. When they decrease adrenergic drive from the brain, there will be decreased activity of sympathetic nervous system, or there will be decreased sympathetic outflow from the brain. And when there is decreased sympathetic outflow from the brain, or decreased outflow of sympathetic nervous system from the brain, it is easily understandable that your blood pressure will go down. But this mechanism you can only tell if in exam they tell that a lipid soluble beta blocker like propanolol is given, then you can tell the antihypertensive action. But if water soluble beta blocker like atenolol is given, you cannot give this mechanism for atenolol, right? Because atenolol actually cannot cross this blood-brain barrier. Only propanolol can cross this blood-brain barrier. So we can go into the slide, right? So uh, beta 1 receptor is blocked by beta blocker in the SA node. When SA node beta 1 receptor is blocked, endogenous epinephrine and non-epinephrine cannot bind with beta 1 receptor in the SA node. This will lead to reduced rate of spontaneous depolarization in the SA node, and this will lead to decrease in heart rate. When heart rate is decreased, cardiac output is decreased, and when cardiac output is decreased, your blood pressure decreases. Second, beta 1 receptor blocks beta 1 receptor in the ventricular myocyte, so endogenous non-epinephrine and epinephrine cannot bind with beta 1 receptor in the ventricular myocyte of the myocardium, and this will lead to decreased contractility of the myocardium, and this will lead to decreased cardiac output, and this ultimately lead to decrease in blood pressure. And third but not the least, beta 1 receptor block beta 1 receptor in the JG cell of kidney, so endogenous epinephrine and non-epinephrine cannot bind with beta 1 receptor in the JG cell of kidney, so there will be decreased renin release, so there will be decreased conversion of angiotensinogen into angiotensin 1, which ultimately leads to decreased angiotensin 2, which is translated as decreased aldosterone. And decreased angiotensin 2 and aldosterone leads to less retention of fluid from the kidney. So when fluid is retention is less from the kidney, your blood pressure goes down, and lipid soluble beta blocker decreases sympathetic drive from the brain, right? They decrease the sympathetic drive from the brain like propanolol. So By this mechanism, they act as antihypertensive beta blocker. Another important use of beta blocker is that they actually used in a condition called hyperthyroidism or thyrotoxicosis, right? What happened? This is your thyroid gland, and you know that your thyroid gland produce T3 and T4. So in some pathological condition, right? For example, in Graves' disease or in a condition called toxic multinodular goiter or these two toxic adenoma. In this condition, there is release of massive amount of T3 and T4 from the thyroid gland. T3 and T4 causes various pathological consequences in the body, but I will not go into details of that because I'll discuss only about beta blockers. What happened? This T3 and T4 is a very small molecule that will enter into the SA node. They will enter into the SA node. And when T3 and T4 will enter into the SA node, they, they lead to increased gene transcription in the SA node. And what happened on the surface of SA node, there is increased expression of beta 1 receptor. Beta 1 receptor is very highly expressed on the surface of SA node. So when this beta 1 receptor, this excess beta 1 receptor will certainly be stimulated by endogenous norepinephrine and epinephrine. Remember that this is central nervous system, this is preganglionic neuron, and this is the postganglionic neuron. And postganglionic neuron release epinephrine and norepinephrine, and there will be excess stimulation of this beta 1 receptor by this norepinephrine and epinephrine. So heart rate will go up. So heart rate will go up. It is normal in a patient of thyrotoxicosis that you can find a heart rate around 120. It is not abnormal, it is absolutely normal. Why? Because thyroid hormone increases the expression of beta 1 receptor on the surface of SA node. So this SA node is super stimulated or very highly stimulated. So now endogenous norepinephrine and epinephrine will stimulate this high concentration of beta 1 receptor, leads to excessive activation of this SA node. So spontaneous depolarization of SA nodes will go high. Suppose previously they are 80, now they will go into 120. So when spontaneous depolarization rate of AC node goes up, it will lead to tachycardia, and person will tell you that they feel palpitation, right? Their heart is racing, they feel palpitation. So what the beta blocker will do? Beta blocker like propanolol will blocks this beta 1 receptor, will blocks this beta 1 receptor. So endogenous non-epinephrine and epinephrine now cannot stimulate this beta 1 receptor, so they cannot increase or super stimulate the SA node in thyrotoxicosis. So in thyrotoxicosis, why we use beta blocker? We use beta blocker because there is increased expression of beta 1 receptor, and to block the effect of this beta 1 receptor stimulation, we give the patient beta blocker, right? This is one mechanism. I will discuss another mechanism why in thyrotoxicosis beta blocker is given. In thyrotoxicosis, and again this is your thyroid gland, and this thyroid gland in thyrotoxicosis release a lot of T3 and T4 in your circulation, and this lot of high concentration of T3 and T4 goes into your uh, ventricular muscle. So suppose this is ventricular muscle, and this ventricular muscle is stimulated by T3 and T4, and when T3 and T4 goes inside the ventricular muscle, they leads to excessive expression of beta 1 receptor on the ventricular muscle. Ventricular muscle is super saturated with beta 1 receptor, so very high expression of beta 1 receptor on the ventricular muscle, and this beta 1 receptor this is central nervous system, this is preganglionic neuron, and this is postganglionic neuron, and postganglionic neuron release epinephrine and norepinephrine, and this epinephrine and norepinephrine will stimulate the beta 1 receptor on the ventricular muscle. So now they will super stimulate this ventricular muscle. This ventricular muscle will be super high stimulated. So when this ventricular muscle is highly stimulated, there will be increased contractility, and this high contractility will lead to high cardiac output, and high cardiac output lead to high systolic blood pressure. So in a patient of thyrotoxicosis, actually systolic blood pressure goes up. It is the systolic blood pressure that goes up. Remember, this is very important. Systolic blood pressure will go up. So to prevent the increase of systolic blood pressure, what we do, we give a beta blocker. Beta blocker blocks this beta 1 receptor, right? We give a beta blocker, and beta blocker blocks this beta 1 receptor. This beta 1 receptor is blocked. Now endogenous epinephrine and non-epinephrine now cannot stimulate these ventricular myocyte that are uh, the surface of which is highly concentrated by beta 1 receptor, and this beta 1 receptor is expressed by thyroid hormones. Now epinephrine and non-epinephrine in the presence of beta blocker cannot stimulate this beta 1 receptor. So now there will be no increase in contractility, and this will lead to no increase in systolic blood pressure, right? So that is another reason why in hyperthyroidism we use beta blockers. Another reason why in hyperthyroidism in beta blocker we use, again in hyperthyroidism there's a lot of T3 and T4, and this T3 and T4 will go into your skeletal muscle, right? Will go into your skeletal muscle. This is your skeletal muscle, and on the surface or spindle of the skeletal muscle, they lead to increased expression of beta 2 receptor. On the spindle of the skeletal muscle, there is a receptor called beta 2, and this beta 2 receptor is located on the spindle of the skeletal muscle, and this beta 2 receptor expression is increased by this thyroid hormone. So again, sympathetic nervous system will not directly innervate this beta 2 receptor, but for your convenience I'll see directly innervation, and this epinephrine will only stimulate beta 2 receptor. Non-epinephrine cannot stimulate the beta 2 receptor. Non-epinephrine can only stimulate the beta 1 receptor, but epinephrine can stimulate the beta 1 plus beta 2 both. So this beta 2 receptor actually is stimulated mainly by epinephrine coming from the adrenal gland, and this when this beta 2 receptor expression is very high, when the source of this epinephrine is actually the adrenal gland, and when this beta 2 receptor that are expressed on the surface of its skeletal muscle is very highly stimulated, this will lead to fine tremor. So to block this fine tremor, what we can do, now we can give the patient beta blocker, right? When you give the patient beta blocker, this beta blocker, suppose we give the patient propanolol, and in the presence of propanolol, epinephrine and non-epinephrine cannot stimulate this high concentration of beta 2 receptor that are expressed on the skeletal muscle spindle. Cannot stimulate this beta 2 receptor, so tremor doesn't occur. And another mechanism why the beta uh, blocker is used in hyperthyroidism, another mechanism why the beta blocker is used in hyperthyroidism is that in hyperthyroidism again you release T3, and T4, and this T3 and T4 will enter into your central nervous system. And when they enter into your central nervous system, there is increased expression of beta receptor in the central nervous system, expression of beta receptor, and this leads to increased adrenergic activity in the central nervous system. And when there is increased adrenergic activity in the CNS, right, when there is increased activity in the CNS become very highly active. So person is restless and anxious due to high activity of CNS, high adrenergic activity in the CNS. Why high adrenergic activity? Because there is now a lot of beta receptor is expressed under the influence of T3 and T4. So patient is restless and anxious. To block this restlessness and anxiousness, we give beta blockers like propranolol. Propranolol will cross the blood-brain barrier and block this adrenergic activity in the CNS. Propranolol, by blocking the beta receptor, they blocks this adrenergic activity in the central nervous system. There will be less anxiety and there will be less restlessness. So these are the mechanism why in thyrotoxicosis or in hyperthyroidism beta blocker is used. So why in hyperthyroidism beta blocker is used? Number one, in hyperthyroidism there will be this is suppose AC node. In AC node there is very high concentration of beta 1 receptor is stimulated, high concentration of beta 1 receptor is expressed on the surface of AC node, and this beta 1 receptor if is stimulated, this will lead to tachycardia and palpitation. Second, in ventricular myocyte, ventricular muscle cell, a lot of beta 1 receptor is expressed by T3 and T4, and this lead to increased contractility, and increased contractility will lead to increased cardiac output, and increased cardiac output lead to increase in systolic blood pressure. Third important thing is skeletal muscle. In the skeletal muscle spindle there is a lot of beta 2 receptor is stimulated, a lot of beta 2 receptor is expressed on the skeletal muscle spindle, and when this beta 2 receptor is stimulated, this leads to tremor. And last but not the least, in CNS, beta receptor expression is increased. This leads to anxiety, restlessness. So what if you give beta blocker? It blocks this beta receptor, so there will tachycardia and palpitation will be prevented, and heart rate will be controlled. Right? Maybe by giving beta blocker, heart rate from 120 will now come down into just 70. Second, there is increase systolic blood pressure by stimulation of beta 1 receptor. If you give beta blocker, this will block beta 1 receptor, so there will there will be no increase in contractility and no increase in cardiac output and no increase in systolic blood pressure. So this change will be prevented, right? And if you give beta blocker, they block beta 2 receptor in the skeletal muscle spindle, and that will lead to prevention of tremor. And when beta blocker blocks beta receptor in the central nervous system, this will prevent anxiety and restlessness. So it also explained in anxious patient there is a lot of adrenergic activity in the central nervous system, so patient is anxious and there will be increased adrenergic drive from the CNS, and this increased adrenergic drive from the CNS will lead to tachycardia and palpitation. And to block all this effect in anxious patient, we can also use propranolol. So propranolol can also be used as anxiolytic, right? Can also be used as anxiolytic. So these are the theories or mechanism why beta blocker is used in thyrotoxicosis or hyperthyroidism. Third, beta blocker can be used in stable angina and after myocardial infarction. So first, let's see stable angina. And it is very tough for me to discuss here what is stable angina because it will take a lot of time. But for Now you believe me that in stable angina, in the coronary artery there is an atherosclerotic plaque, and this atherosclerotic plaque blocks the lumen by 70%, right? Block the cross section by 70% of the lumen of coronary artery. This is the coronary artery. Coronary artery is the artery that supplies oxygen and nutrition to the heart. So this is the cardiac heart muscle. So this is the heart, and coronary artery supplies oxygen and nutrition to the heart, right? So when a particular coronary artery, the lumen of a particular coronary artery is blocked by 70% at rest, the oxygen supply is normal. But when person undergo exertion, oxygen supply become inadequate. There is inadequate oxygen supply, and when there is inadequate oxygen supply, there is undergo cardiac muscle will suffer from hypoxia, and when hypoxia occurs, there will a lot of metabolites will be produced in the cardiac muscle, and this lot of metabolites that are produced in the cardiac muscle will stimulate pain fiber in the myocardium, stimulate. There are a lot of pain fiber is very highly concentrated in the interstitial spaces of the myocardium. So when these metabolites like ADP, adenosine, or hydrogen or lactate, this metabolite in hypoxic condition will stimulate the pain fiber in the cardiac muscle cell, and patient will feel chest discomfort or chest tightness, right? Or compression like sensation in the chest, and this sensation can radiate anywhere from C7 to T4 thoracic 4 dermatome, right? Anywhere from C7 to T4 dermatome. So these are the basic some very superficial thing about stable angina. Coronary artery is 70% blocked. What you can relieve angina, one thing you can do, you can increase the oxygen supply. Why angina occur? Angina occur due to hypoxia. So what you can do, you can increase the oxygen supply, but you cannot increase the oxygen supply in this condition, right? Because in stable angina is a condition where the oxygen supply to the heart is maximum. Oxygen supply cannot be increased further, and it is the beyond of my discussion why oxygen supply is maximum in stable angina. If you want to understand, you can study specific cardiovascular books of medicine to understand why there is oxygen supply is maximum in stable angina and oxygen supply cannot be further increased. So what we can do, we have just left one option. We can decrease the oxygen demand of the myocardium. In stable angina, what we can do, we can decrease the oxygen demand of the myocardium. So what are the factor that will determine the myocardial oxygen demand? Again, to understand the oxygen demand of the myocardium, you should study specific CVS books. But if you just trust me, oxygen demand of the myocardium mainly depend on 3 to 4 factors. Number one, it depends on heart rate. Number two, it depends on contractility or force of contraction of the heart. Number three, it depends on afterload. Number four, it depends on preload. Preload means venous return, right? Preload means venous return. So if your heart rate goes up, your oxygen demand will go up, right? Then again, if force of contraction will go up, your oxygen demand will go up. If your preload or venous return will go up, your oxygen demand will go up. And if your afterload will go up, your oxygen demand will go up. What the beta blocker do? If you give the beta blocker blocks beta 1 receptor in the SA node, right? So what the beta blocker do? Beta blocker blocks beta 1 receptor on the SA node. When the blocks beta 1 receptor in the SA node, your heart rate will go down. And when your heart rate will go down, your oxygen demand will go down, right? So when your oxygen demand will go down, then myocardial hypoxia will not occur. And if the myocardial hypoxia will not occur, it means there is no production of this type of metabolites like lactate or hydrogen or adenosine. So there will be no stimulation of the pain fiber. Pain fiber will not be stimulated, so there will be no discomfort of angina. There will be no discomfort, chest discomfort or chest pain or compression like sensation of angina, because beta blocker, by inhibiting or blocking the beta 1 receptor in the SA node, they will decrease the heart rate and decrease the oxygen demand. Second, beta 1 receptor block beta 1 receptor in the ventricular muscle cell. In the ventricular muscle, when the ventricular muscle cell beta 1 receptor is blocked, or ventricular myocyte beta 1 receptor is blocked, there will be less contractility. That means there will be decreased force of contraction, and when there is decreased force of contraction, oxygen demand will go down. So that is why in stable angina we'll use beta blocker, right? Again, to understand details of these things, you need to study specific cardiovascular books. So now come, what is the advantage of using beta blocker after myocardial infarction? So what happens, suppose this is heart and portion of the heart undergo infarction. When myocardial infarction occur, cardiac output will go down, and when cardiac output will go down, blood pressure will go down, and this fall in blood pressure will be sensed by baroreceptor. Baroreceptor will sense this, and when baroreceptor will sense this, right, what will happen? Let's see. So when we have fall in blood pressure, baroreceptor will sense that, and they will send this information through the vagus and glossopharyngeal nerve into the vasomotor center of medulla. Vasomotor center is located in the medulla. They'll send this through the 9 and 10 cranial nerve, vagus and glossopharyngeal nerve, and from the vasomotor center there will be increased sympathetic outflow to the brain, to the heart, sorry. There will be increased sympathetic outflow to the heart or to the whole body. And when there is increased sympathetic outflow, what will happen? There will sympathetic nervous system has this type of preganglionic neurons in the spinal cord. So what happens if there is increased sympathetic outflow? Sympathetic nervous system has preganglionic neuron in the spinal cord, and this preganglionic neuron synapse with another neuron called postganglionic neuron, and this postganglionic neuron will now activate the ventricular myocyte, right? This is the ventricular muscle cell, and these postganglionic neuron release epinephrine and norepinephrine, and this norepinephrine and epinephrine will stimulate this ventricular muscle cell. Initially this is helpful initially, but if these events occur for 1 or 2 years, 1 or 2 years or 3 years, there is increased sympathetic drive from the brain, and brain is continuously releasing epinephrine and norepinephrine, and that means postganglionic neuron is continuously releasing epinephrine and norepinephrine to the ventricular muscle cell. This ventricular muscle cell undergo apoptosis. So if there is chronic sympathetic drive from the brain, this ventricular muscle undergo apoptosis, and in the heart, suppose in the heart already there is some necrotic segment, and now there is some viable segment, and in viable segment in long run, due to high sympathetic drive, there is some apoptotic and fibrotic area, and this events is called cardiac remodeling. And due to this cardiac remodeling, what whatever the portion or what amount of portion that is viable in the heart ultimately become weak. This viable portion of the heart become weak. There's many mechanisms, but one of the important mechanism of cardiac remodeling is chronic increase in sympathetic nervous system activity from the brain. If there is chronic sympathetic drive to the heart from the brain, this heart muscle undergo apoptosis and fibrosis. And this is called cardiac remodeling. And this cardiac remodeling occurs in the healthy segment of the heart. And when there is cardiac remodeling occur in this healthy segment of the heart, this healthy segment of the heart become weak, so there will be decreased cardiac output, or there is decreased fall in cardiac output, and this lead to ultimately congestive cardiac failure. So after MI, if we give beta blocker, and this beta blocker, actually what happens? So let's see again. So after MI, as there is falling cardiac output, this falling cardiac output lead to increased sympathetic nervous system drive from the brain, and this increased sympathetic nervous system will release non-epinephrine and epinephrine, and this non-epinephrine and epinephrine will continuously stimulate this beta 1 receptor, and this lead to ultimately apoptosis of the muscle, ultimately fibrosis of the muscle. So then myocardial contractility goes down because the myocardium lose further myocyte. So myocardial contractility falls seriously, and this will lead to congestive cardiac failure. So how we can prevent it? We can give this patient beta blocker. If beta blocker is given after myocardial infarction, sympathetic drive from the brain is less, or sympathetic drive, there is sympathetic drive from the brain, but the brain cannot stimulate this beta 1 receptor and cannot cause this serious sequence like cardiac remodeling. So beta blocker prevents cardiac remodeling. So beta blocker prevents cardiac remodeling after myocardial infarction, so we can call that beta blocker provides survival benefit to the patient. Any drug that prevents myocardial remodeling or cardiac remodeling after MI, after myocardial infarction, myocardium undergo remodeling. Initially, this remodeling is helpful, but in the long run, this remodeling is very detrimental for the heart. So, any drug that blocks this cardiac remodeling. What are the drugs that blocks this cardiac remodeling? One is beta blocker, another one is angiotensin receptor blocker, another one is spironolactone. So these drugs blocks cardiac remodeling. So any of these drugs will be helpful after myocardial infarction, and because they prevent cardiac remodeling, and they provide, it is not surprising that they will provide survival benefit to the patient, or the patient will survive more, right? So beta blocker like timolol is used in glaucoma. Glaucoma means there is increased intraocular pressure, and increased intraocular pressure can injure your optic nerve, and that can lead to blindness, right? That can lead to blindness gradually, progressively. That can lead to blindness. And one of the important determinant that determines the pressure inside the eye is aqueous humor. Aqueous humor. And aqueous humor in the eye, there's ciliary body, this is ciliary body, and this ciliary body will form the aqueous humor. And on the surface of ciliary body there is beta receptor, and when this beta receptor is stimulated, this stimulation leads to increased formation of aqueous humor, and increased aqueous humor will lead to increased intraocular pressure. So beta blocker like, for example, timolol. What do you have to remember the name of timolol? This timolol actually blocks this beta receptor in the ciliary body. So when timolol blocks this receptor in the ciliary body, this will lead to formation of aqueous humor. And when aqueous humor formation is reduced, this leads to reduction in intraocular pressure. So beta blocker is helpful in glaucoma. So beta blocker is also helpful in the cancer of adrenal medulla. From adrenal medulla, there is cancer called pheochromocytoma. Pheochromocytoma actually the cancer of adrenal medulla. In this type of cancer, patient release a lot of epinephrine and non-epinephrine into the circulation. But the release is not continuous, the release is episodic. So suppose there is now release of non-epinephrine and epinephrine into the circulation. So in the circulation, non-epinephrine and epinephrine concentration goes down. Then again there is no release. Again there is release of non-epinephrine and epinephrine, and again there is no release. So when this tumor release epinephrine and non-epinephrine into the circulation, there will be increased effect of non-epinephrine and epinephrine into the circulation. So there will be increased effect of non-epinephrine and epinephrine. So there will be increased effect. So some of the important effect is that this non-epinephrine and epinephrine will stimulate the beta 1 receptor on the SA node. So they will stimulate the beta 1 receptor on the SA node. So what happens when the beta 1 receptor in the SA node will be stimulated? There will be tachycardia and palpitation, right? There will be tachycardia and palpitation. So, and when this non-epinephrine and epinephrine will stimulate the alpha 1 receptor in the blood vessel, there is alpha 1 receptor, especially in the arterial or smooth muscle. And when this non-epinephrine and epinephrine stimulate alpha 1 receptor in the blood vessel, there will be vasoconstriction, and this leads to hypertension. When there is vasoconstriction, there is increase in total peripheral resistance, and this leads to hypertension. In epinephrine and non-epinephrine also leads to headache, and epinephrine and non-epinephrine also stimulate the sweat glands, so there will be profuse sweating. Actually, epinephrine and non-epinephrine will increase the sympathetic drive, and this sympathetic drive will lead to increase in sweating. So these events will occur in episode, and in this situation, in this episode, we can give the patient beta blocker, because if we give the patient beta blocker, SA node, beta 1 receptor in the SA node will be blocked, and we should also give the patient alpha blocker. An alpha 1 receptor in the blood vessel will be blocked. So in pheochromocytoma, both alpha blocker plus beta blocker is used, right? Both alpha blocker and beta blocker is used, and also this epinephrine and non-epinephrine will stimulate the beta 1 receptor that are located in the ventricular muscle, right? In the ventricular muscle, when beta 1 receptor in the ventricular muscle is stimulated, there will be increased contractility, and this will lead to increased blood pressure. So beta blocker will also block this beta 1 receptor in the ventricular muscle, so that increase in blood pressure will not occur, right? So in pheochromocytoma, beta blocker blocks beta 1 receptor in the ventricular muscle, also blocks beta 1 receptor in the SA node, and prevents the action of very high concentration of epinephrine and non-epinephrine that are released in episode. This is very important, that are released in episode in pheochromocytoma, right? Beta blocker can also helpful in some other condition like essential tremor. Essential tremor means there is tremor of the person and you investigate but you don't find any cause. Then you can give this patient beta blocker. Beta blocker, again I say, you can give this patient propanolol, and propanolol blocks the beta 2 receptor in the muscle spindle, right? Propanolol blocks the beta 2 receptor in the muscle spindle. You can give this patient propanolol, and blocks the beta 2 receptor in the skeletal muscle spindle. When beta 2 receptor is blocked by propanolol, tremor will not occur. So this beta blocker is helpful in essential tremor, right? Again, in some patient in acute anxiety state, some patient is very anxious, anxiety disorder, beta blocker can be used as anxiolytic. Beta blocker like propranolol, because propranolol is a lipid soluble beta blocker. These are lipid soluble, so they can cross the blood-brain barrier. They can cross the blood-brain barrier, and then they enter into the central nervous system. Suppose this is the central nervous system, and when they enter into the central nervous system, they reduce the adrenergic drive. By blocking the beta receptor, they decrease adrenergic drive, and one of the component of anxiety is increased adrenergic drive in the central nervous system. So patient with anxiety, restlessness, or anxiety disorder, we can use propranolol beta blocker, right? This is very important. Another important use of beta blocker is that it can, in our country, it is highly used in prophylaxis of migraine. Prophylaxis of migraine. So you can study migraine headache from books in details. What happens is migraine headache. There is a headache episode, and then the person become normal. So this is the normal, and this is the headache. And again the headache come, and again the person become normal. Again the headache come, again the person become normal. Again the headache come, again the person become normal. So there is headache come in episode in migraine headache, prophylaxis of migraine. So what does it mean? In this episode, in this headache episode of migraine, you can use the following drugs. Number one is paracetamol, along with antiemetics, because what sometimes person is feeling nausea or vomiting. So paracetamol or acetaminophen with antiemetics, or you can use sumatriptan or group of drug, triptan group of drugs, sumatriptan or zolmitriptan. You can use triptan in this acute episode. But between the acute episodes, suppose in this portion, what drug is helpful? In this portion, you can use two or three drugs. One of the important drugs is propranolol. Propranolol. Second drug is tricyclic antidepressant like amitriptyline, and third drug is topiramate. So these are clinical information that will be very helpful for your clinical practice, that in this episode these three drugs is highly or hugely used by neurologists. So what does prophylaxis mean? Prophylaxis means you put the patient beta blocker in this situation, and when you give the patient beta blocker like propranolol, what is happen? Suppose there is a headache, and after long term there is no headache. Maybe after 4 or 5 months you get a headache. So these drugs, propranolol, tricyclic antidepressant, or topiramate, actually act as migraine prophylaxis, because when they are used, the episode or frequency of migraine is reduced. There is decreased frequency of attack of migraine headaches. So this is the mechanism why in migraine headache beta blocker is used as prophylaxis, right? Along with maybe amitriptyline or topiramate. And in acute event, mostly I like to manage patient with 2 tablets of acetaminophen along with some antiemetic. If that doesn't work for this patient, then you can use sumatriptan, but don't use triptan in the first line, right? So initially try to manage patient with simple paracetamol or antiemetic. So these are prophylaxis, but the mechanism how beta blocker act as anti-migraine, I don't have any explanation. The answer is I don't know. If you know, you can search in the internet, but I don't find any answer, and the mechanism I don't know. There is another important use of beta blocker, and this is Esophageal varices. Esophageal varices. What happened in patient with chronic liver disease? In chronic liver disease, suppose if the liver is fibrotic, if your liver is damaged, if your liver is damaged, this is called chronic liver disease. And in chronic liver disease, the blood that drain through the liver is through the portal vein, and from the portal vein blood cannot drain easily through the liver. So what they do, to try to use different channel, and portal vein has connection with esophageal vein or some vein in the lower part of the esophagus, right? So some of the blood from the portal vein try to drain from the lower part of the esophagus, and when they try to drain from the lower part of the esophagus, right, this blood comes from the GIT or spleen, and when they try to drain from the lower part of the esophagus into the systemic circulation, this vein in the lower part of the esophagus become dilated. So there is dilation and tortuosity in the vein of the lower part of the esophagus in a patient with chronic liver disease. So what is esophageal varices? Esophageal varices, you can see a picture from Google. This is a picture from Google, and in esophageal varices you can see this lower end of esophagus, and there is dilated submucosal veins. The submucosal vein become dilated plus tortuous, and if this vessel rupture, there will be massive hematemesis. There will be massive hematemesis, and this will lead to death of the patient. And this is the most common cause of death, one of the most common cause of death in patient with chronic liver disease, that these esophageal veins that are located in the lower end of the esophagus will rupture, and this leads to massive hematemesis, right? So what you can do, you can suppose a patient has chronic liver disease, what you can do, you can do certain things. Suppose you can ligate these vessels. This is called variceal man ligation. Man ligation. But you also can give this patient beta blocker like propanolol, and it is seen in clinical trial that beta blocker is highly effective in reducing the episode of hematemesis or decreasing the incidence. Beta blocker is highly effective in decreasing the incidence of rupture of esophageal varices. They prevent the rupture or decrease the risk of rupture of these esophageal varices. So when beta blocker is given, actually, I don't know the accurate explanation. There are some explanation in the books. Some books say beta blocker will reduce heart rate and reduce cardiac output. When the cardiac output is reduced, there will be less blood going to the esophageal varices. Less blood is going to the esophageal varices, so there will be less chance of rupture. So there will be less pressure of blood. When less blood is going to the esophageal varices, there will be less pressure of blood, so there will be less chance of rupture. There will be less chance of rupture of esophageal varices. Again, another authority says beta blocker actually directly works on the esophageal varices. They directly work on the esophageal varices, and they actually cause a shrinkage of the varices. They actually cause a shrinkage of the varices by directly work on the esophageal varices, right? So these some authority beliefs, but I don't know what is actually true. But the most important thing is that if we give beta blocker to a patient of esophageal varices of CLD or chronic liver disease, this patient will benefit massively, right? So this is a very important indication of beta blocker. Prophylaxis for bleeding against esophageal varices in CLD. This is very important indication. There are many other indications. One of the important is that beta blocker is useful in supraventricular tachycardia, atrial fibrillation flutter, But these actually beyond of my discussion, so I'll just give you. And again, beta blocker is helpful in dissecting aortic aneurysm. Dissecting aortic aneurysm, what you want to do, you want to reduce the systolic blood pressure. What the beta blocker will do, beta blocker will block beta 1 receptor in the SA node, so this will lead to decrease in heart rate. Also, beta blocker will block beta 1 receptor in the ventricular myocyte. This will lead to force of contraction, reduced force of contraction. This will lead to reduced cardiac output, and this will lead to reduced systolic blood pressure. So this reduction in systolic blood pressure in dissecting aortic aneurysm is helpful. So these are some important indications of beta blocker. Now we'll see some important side effect of beta blocker. One of the important side effects of beta blocker is that it will lead to bradycardia. It will lead to excessive reduction in heart rate sometimes. Why? Because beta blocker blocks beta 1 receptor in the SA node. So beta blocker blocks beta 1 receptor in the SA node. When this blockage is excessive, so SA node activity will be less. SA node activity will go significantly down, and this will lead to decreased heart rate, sometime below 60, suppose 50, and this condition is called bradycardia. So beta blocker can lead to bradycardia. Another important thing is that beta blocker is contraindicated and should not be used. Again, I say non-selective beta blocker like propranolol should not be used in patients with bronchial asthma and COPD. Bronchial asthma and COPD. Why? Suppose this is central nervous system, right? And from central nervous system, preganglionic neuron comes, and the synapse with postganglionic neuron, and this postganglionic neuron release norepinephrine and epinephrine, and this norepinephrine and epinephrine will stimulate bronchial smooth muscle. Suppose this is bronchial smooth muscle. So this bronchial or smooth muscle contain beta 2 receptor, beta 2, and when this epinephrine and norepinephrine stimulates this beta 2 receptor, what happens? There will this bronchial smooth muscle relax. There is relaxation of bronchial smooth muscle. Relaxation of this bronchial smooth muscle. When this bronchial smooth muscle relax, this will lead to bronchodilation. Bronchodilation. This is very, very important. In a patient with asthma and COPD, remember, this is central nervous system, this is preganglionic neuron, and this is postganglionic neuron. And this postganglionic neuron release epinephrine and norepinephrine. This epinephrine and norepinephrine is endogenous, that is, they are synthesized in the body, and they stimulate the beta 2 receptor, and this leads to bronchodilation. What happened in bronchial asthma? In bronchial asthma and COPD, the bronchus and bronchioles are narrow. This is obstructive airway disease, my friend. This is obstructive airway disease. Obstructive airway disease. These bronchus and bronchioles are obstructed, right? There is, suppose this is bronchus and this is bronchioles, and this bronchioles is narrow, right? This bronchioles is narrow. In asthma and COPD, this bronchiole is narrow. There's narrow bronchioles or bronchus. And in this condition, what happen if you give the patient beta blocker? If you give the patient beta blocker, look what happen. Suppose this is central nervous system, this is preganglionic neuron, and this is postganglionic neuron, and postganglionic neuron release epinephrine and norepinephrine. I made a mistake actually. Norepinephrine doesn't stimulate the beta 2 receptor. Correct myself, I am extremely sorry. Only epinephrine will be here. This epinephrine actually produced in the adrenal medulla, and they enter into the blood, and this epinephrine will ultimately take up by this neuron and packaged into vesicles of neuron for subsequent secretion. So that is the source of epinephrine. The source of epinephrine in the nerve endings of sympathetic nervous system is actually adrenal medulla. And this epinephrine now is secreted, and this epinephrine stimulates the beta 2 receptor, because non-epinephrine cannot stimulate the beta 2 receptor. Only epinephrine can. So epinephrine will stimulate the beta 2 receptor and produce bronchodilation. If you give patient beta 2 blocker like propranolol, if you give a patient a drug which actually blocks beta 2, what happened? Look at, my friend, what happened. You, in a patient with asthma, they already have spastic airway or constricted airway or narrowed airway, and you give the patient beta blocker. What will happen? Endogenous bronchodilation will not occur because beta 2 receptor is blocked. So endogenous non-epinephrine and epinephrine cannot maintain the dilated bronchi. So what will happen? The bronchi and bronchial will be extremely narrow. Extremely narrow. Already they are narrow. Suppose this is the bronchial, already they are narrow, and now by giving beta blocker, you make them further narrow. So what will happen? You will don't get oxygen, and you also cannot eliminate carbon dioxide. You cannot eliminate carbon dioxide, and this is actually a respiratory failure. Your respiratory system fails, and what happens if your respiratory system fails? You'll die. So never give a non-selective beta blocker and even selective beta 1 blocker to a patient of bronchial asthma, because those drugs which is called beta 1 blocker like atenolol, they are not 100% beta 1 blocker. They also have some beta 2 blocking properties. So never better give beta blocker to a patient of bronchial asthma. I have find two patients that are taking beta blocker and suffer serious consequences, and it is very hard for us to manage the patient later. And so never give this patient beta blocker, because it will block the bronchodilation, and then the bronchi will that are already narrow, beta blocker will make them further narrow, and this is dangerous, my friend. This is dangerous. Beta blocker can also produce heart block, right? How? There is sympathetic nervous system. This is preganglionic neuron, and this is postganglionic neuron. Postganglionic neuron release epinephrine and non-epinephrine, and this epinephrine and non-epinephrine will stimulate AV node and stimulate beta 1 receptor in the AV node. And when epinephrine and non-epinephrine stimulate beta 1 receptor in the AV node, conduction through the AV node is maintained. Conduction through AV node is maintained. Node is maintained. If you give beta blocker, AV nodal conduction become very slow. AV nodal, if you give beta blocker in very high dose, conduction through the AV node becomes slow. When AV node conduction becomes slow, impulses from atria cannot go to the ventricle, so impulses from atrium that are produced in the AC node can only go through AV node, right? If this AV node is blocked, impulses from AC node cannot, or atria cannot go to the ventricle, and this condition is called heart block. So beta blocker can produce heart block. Beta blocker can also precipitate cardiac failure because they reduce contractility of the cardiac muscle. But some beta blocker, not all, is helpful in some situation in heart failure, like carvedilol. But I'll not go into details. To understand that, you have to understand the Frank-Starling curves, the flat portion, the steep portion, and also uh, the flat portion and steep portion of Frank-Starling curve, and also the ejection fraction conception, and all these things are taken into account before prescribing beta blocker like carvedilol to a patient of heart failure. But for your level, you should actually avoid this discussion, But if some students and doctors think that they're competent enough, they can actually go through details, but I'll not go into details. That if heart flow failure is severe, you cannot use the beta blocker, right? And this will actually worsen the symptom by reducing the contractility. Beta blocker, particularly non-selective beta blocker, should be avoided in a patient of diabetes who are taking especially two drugs, one is sulfonylurea and another one is insulin. Why? Because person who is taking sulfonylurea and insulin, if they miss a meal or due to various reasons, this drug has a tendency to lower your blood glucose level. So this drug has a tendency to produce hypoglycemia, or suppose your blood glucose level is below 4 or below 3.5. And when hypoglycemia occurs, what happens? Your hypothalamus actually senses that you're hypoglycemic, then from the brain there is increased sympathetic nervous system drive. There is increased sympathetic nervous system activity. Why? Because they want to warn you that you're hypoglycemic. They want to warn you. So what happened? If this there is increased sympathetic nervous system activity, there is release of norepinephrine and epinephrine, and this norepinephrine and epinephrine will stimulate the SA node, will stimulate the beta 1 receptor in the SA node, and this will lead to heart rate increase in heart rate, and this will lead to tachycardia and palpitation. So first response in hypoglycemia, that there will be tachycardia and palpitation. Second important response of hypoglycemia is that this epinephrine will stimulate the beta 2 receptor in a skeletal muscle spindle. They will stimulate the beta 2 receptor in the skeletal muscle spindle. So what will happen? There will be tremor. And third important thing is that these uh, these sympathetic nervous system will stimulate sweat gland, and this will lead to sweating. And fourth important is event is that the sympathetic nervous system will activate adrenal medulla, right? There is adrenal cortex and adrenal medulla. From the adrenal medulla, epinephrine will be released, and this epinephrine will enter into your blood. Through the blood, this epinephrine will go to the liver. On the hepatocyte of liver, on the hepatocyte of liver, there is beta 2 receptor. There's beta 2, and this epinephrine will stimulate this beta 2 receptor. When epinephrine stimulates the beta 2 receptor on the hepatocyte, this is liver, on the hepatocyte of the liver, there will be glycogenolysis. There will be glycogen breakdown. So glycogen will break down. Glycogen breakdown. And when there is glycogen breakdown, glucose is produced, and this glucose is reduced into the is released into the circulation. So epinephrine released from the adrenal medulla will activate beta 2 receptor in the hepatocyte and will produce glycogenolysis. So glycogen will break down, and this leads to release of glucose into blood. So all these things, these are something that warns you about hypoglycemia, like tachycardia, palpitation, tremor, sweating. These are the warning signs of hypoglycemia. And if blood glucose reduces further, there will be decreased blood supply to the brain, and there will be brain dysfunction, like patient may various function of the brain may hampered, like vision and other problem patient may feel, right? Because all the function of the central nervous system is dependent on glucose. But if initially these are the initial response, like tachycardia, palpitation, tremor, and sweating, these are the initial response to hypoglycemia. And adrenal medulla will try to recover the hypoglycemia, or try to counteract the hypoglycemia by releasing epinephrine. So what will happen if you give a beta blocker, right? What will happen? Let's see. So patient of diabetes, and suppose if they receive insulin or sulfonylurea drug, if their blood glucose become dangerously low, Then there will be increased sympathetic activity from the brain, and increased sympathetic nervous system activity will try to stimulate the SA node, try to stimulate the beta 1 receptor in the SA node. So patient will feel tachycardia and palpitation. But if you give beta blocker, patient will not feel tachycardia and palpitation, right? They will not understand that they are hypoglycemic. Again, this sympathetic nervous system from the brain will activate the beta 2 receptor in the skeletal muscle, spindle, and there will be tremor. If you give a non-selective beta blocker, this non-selective beta blocker block beta 2 like propanolol, and patient will not feel tremor. They are hypoglycemic. Body try to warn them by producing tremor, try to warn them, warning, try to give warning to them that they are hypoglycemic by producing tremor, and you give propanolol and block the beta 2 receptor so the person will not feel tremor. And body try to recover this hypoglycemia by stimulating the beta 2 receptor and producing glycogen breakdown to release glucose into the circulation. And you block, give beta 2 receptor blocker like propanolol, and you block this beta 2 receptor, so the recovery from the hypoglycemia will not occur. This is the recovery mechanism from hypoglycemia. So you block the recovery. So what happens if you give the patient beta blocker to a diabetic patient? They will not, when they undergo hypoglycemia, this is very dangerous. Patient will die from hypoglycemia. They will not feel tachycardia and palpitation, and they will not feel any tremor, and there will be no or delayed recovery from hypoglycemia. Their recovery mechanism from the hypoglycemia is impaired. Recovery mechanism is impaired. So this is dangerous. That is why in diabetic patient you should never use non-selective beta blocker. Better to avoid beta blocker, but if you want to use a selective beta blocker like atenolol or metoprolol, but never use a non-selective beta blocker like propanolol, right? So in diabetic patient, if patient undergo hypoglycemia, they will not feel the warning sign of hypoglycemia. There will be no warning sign that will warn the patient. Patient will not feel palpitation or tremor, but patient will sweat. That is sweating is not blocked by beta blocker, but patient, there will be no palpitation or tremor that warns the patient. So we call this warning sign. This warning sign will not occur, and there will be recovery mechanism from hypoglycemia is impaired. So we don't want to use beta blocker in a diabetic patient. Rather, a beta blocker has also decreased the HDL level, that is good cholesterol, and they tend to increase the LDL level, that is bad cholesterol, and that can lead to coronary artery disease. That increases the risk of coronary artery disease, right? And beta blocker has another contraindication. It should not be used in peripheral vascular disease, right? In peripheral vascular disease, vessel is already narrow and there will be decreased blood flow to the limb, right? So there will be decreased, vessel is narrow and there is decreased blood flow to the limb, and there will be decreased blood flow to the limb blood flow is reduced, and this lead to limb ischemia. What happens if we give a beta blocker? Suppose this is the cross section of a blood vessel, for example arteriole, and arteriole has tunica intima, media, and adventitia, and tunica media of arteriole contain a smooth muscle, and suppose this is the smooth muscle of blood vessel, this is the smooth muscle of blood vessel, and this smooth muscle of blood vessel contain two receptors. One is alpha 1 and one is beta 2. Stimulation, if you stimulate the alpha 1 receptor, that will lead to vasoconstriction, right? So if you stimulate the alpha 1 receptor, suppose the vessel become this and it will go like this. There will be narrowing of the blood vessel will become narrow. And if we stimulate the beta 2 receptor, there is vasodilatation. Suppose the vessel is like this Now the vessel will be like this. There will be vasodilatation. So beta 2 receptor stimulation is one of the important mechanisms for maintenance of vasodilatation in blood vessel, as particularly that supply the skin and muscle and skin and skeletal muscle. This beta 2 receptor in the blood vessel is important. And if you give beta blocker like propranolol, this beta 2 receptor is blocked. So what happened? There will not be any vasodilatation. Rather, this vessel undergo contraction. In peripheral vascular disease, already the vessel is narrow. Already the vessel is narrow in peripheral vascular disease. Already the vessel is narrow, and you give beta blocker like propranolol and makes this vessel further narrow. What will be the consequence? If you make this vessel further narrow by giving beta blocker, and this will lead to limb ischemia. This will aggravate the limb ischemia, and this can lead to necrosis and gangrene. So these are important discussion about beta blockers. I may skip some, but you can see the books, and these are important. Thank you very much for listening it with patience. Thank you very much.